If you're a professional in the acute, needing to move your patient to another community service, you still go through the SPA. It might sound like it's adding a step, it isn't. You know, dietetics don't accept referrals from physiotherapists in the community. Has to go through the GP. Because physiotherapists would never know why to refer to a dietitian. So these are colleagues, you know, and I managed the allied health professions when I came into the trust first, and I had 9 allied health professions, including music therapy and art therapy. Well, you tried to get referred to music therapy because they just would not accept the referral. So we had to break down those silos as well. Now, anybody can go through the single point of access. It's not determined by your profession. So there is no service within my services that you cannot refer to. If you're a social worker, a dietitian, a nurse, an ancillary nurse, you don't have to be a qualified nurse. If you're out doing home care with a patient and you think they need something, refer them in. We've broken down that barrier completely. So you'll remember your deal or no deal. There's one pathway now. There isn't all those little black lines over here that don't work. So on this side, you've got a GP. And Ron, this is probably particularly useful so that you can see the diagram of the surgical route, okay? Over there, you've got speciality services, and what I mean by that is acute consultant services, orthopedics, GI, neurology, whatever, okay? That is entirely taken care of with a system in the UK called Choose and Book. It's part of the national programme for IT, and every GP uses it now. And what the Choose and Book system does is you go into your GP, they have a look at your dodgy hip. They say you need to go to orthopedics. They open up the Choose and Book national window. And they say to you, okay, here are your choices. You can go to the hospital 5 minutes away from you, which has a it won't have, because that'll be within 18 weeks, has an 8-week waiting time. You can go to the one 50 miles away that has a 2-week waiting time. Well, actually, my mum lives in Gloucestershire, and if I'm going to have a hip replacement, I could stay with her and she can make my breakfast. So what I'd like to do is there any chance I can go to a hospital in Gloucester? Yes, you can. And as an NHS user, you're entitled to go anywhere in the UK to have your surgery. You don't have to go within your PCT area. You can go anywhere, okay? Including, depending on where you are, France, Belgium, etc. And they'll ship you across and they'll ship you home. That's taken care of. Now, I want to talk about that in terms of the future. Don't get me wrong, it's not a bad system. But it is when you think they only really like consultant-led services on Choose and Book. And community services are not consultant-led. So you've got chronic back pain and your GP thinks you need to go somewhere. He opens up Choose and Book. You're not going to see my highly specialist physiotherapy service there. And I have a problem with that. So what I'm trying to leverage is the rules of Choose and Book. Choose and Book portal should be opened when community and primary care services have been exhausted. GP, SPA, this is your SPA here, this target, over to community services, into a community bed. So GPs can refer directly into our rehabilitation beds. They're not there solely to take from the acute. Okay? And that's the way the pathway works. So the GP has 2 systems. Choose and Book if he wants to refer to a consultant inappropriately. I'll give you a really good laugh about it. Our neurosurgeons, we've got a really highly specialist team of physiotherapists in musculoskeletal. They do, Clint loves me talking about these. I tell them about this SMAS every time. We were shortlisted for a major award for this team. They do ultrasound diagnostics, they order MRIs, they order CTs, they do ultrasound guided joint injections without any supervision from a medic. They prescribe all full range from the British National Formulary. They are a one-stop shop for musculoskeletal, right? So how did we get away with that? Because we went to our consultant orthopedics and said, why in the name of God do you want to be seeing chronic back pain? You're a surgeon. You like holding knives for some strange reason and knocking people's hips off with a chisel and a hammer. Isn't that what you really want to do? Yeah. So why don't you just send us the back pain? Well, but what will you do with it? Well, if you help us, we can do all this stuff. So now you've got a really, really good pathway, okay? One of our biggest advocates, I was saying to Ron last night, with our neurosurgeons. because neurosurgeons are really precious. I love them. And so when you say to them, surely you don't want to see a back unless you know you're going to be doing the microsurgery on the L5 disc that's going to save his pain without paralysing him. Yes, that's what I want to do. Okay, so send everything else to us. So the GPs would send the referral for chronic back pain to the neurosurgeons now, because orthopedics wouldn't accept them. They said, send them to the SMAS. So they said, oh, I know what I'll do. I'll send them to a neurosurgeon because they see backs as well. And the neurosurgeon said, actually, we're not seeing them either. But because of Choose and Book, that's our local hospital, because of Choose and Book, the patient would come back and say, or the GP would say, they've refused your referral in the local acute, which you chose. Let's see where else we can inappropriately refer you to. And that was one of the lessons for Choose and Book. If you can't inappropriately refer locally, you can inappropriately refer somewhere else, rather than us imposing the rule to say you're not allowed to refer back pain anywhere except to this service, and when we see it and decide it should go further, we'll use the Choose and Book portal and we'll send the patient to their choice of treatment. Okay? So that's the pathway. Full local configuration, which again was extremely important for us. An admin team only, 4 staff covering 250,000 population. It's a lot. How many referrals a month to community services? Remember, this is not acute. Clint? 2,300 referrals a month. Huge. That is huge for community services. Okay? And a portion of those are to rapid response, are to the beds. That's direct acute saving. I can go to my commissioners and say, that is the ROI right there in front of you. If they didn't have this choice, they would have been in a bed in the acute because they were unwell enough to be in a bed. And the only other choice is acute. We have enabled a choice for community beds, which they pay a lot less for, as you can imagine. And it operates 8 in the morning till 10 at night, which was also important to us because it's extended hours in GP surgeries now in the UK. And it also operates weekends. Okay? The benefits. I class this the 4 Ps. Patient benefits. Is it clear that the patient benefits here? Yeah? Closer to home, community service, not sitting in an acute hospital, not sitting in A&E for 4 hours. The pathway is simple. It's understandable. GPs get it. Community services get it. Acute get it. They refer because it's easy. So the pathway is enabled. Productivity, you have to imagine the difference now in my teams because they don't deal with referrals all day. They're not running around and saying, this was faxed through today, can you have a look at that and see if it's suitable for the dietetic specialist consultant? Or should we send it to the dietetic not so specialist consultant? So that productivity has been increased hugely. I would suggest that the investment we've made in the Strata has probably been paid for out of the admin teams within the departments. And planning. And this is a really important one for me. Yesterday, and I promise I had this presentation written before yesterday, the planning bit is around this intelligence versus data. So it allows us as an organisation to know what's happening in our services. Which brings me on to this. This is what I class as the intelligence hierarchy. So this here, yes? And I think the shape of it is probably right. Down here are your data enterers. So in the service, pumping their stuff into your Excel spreadsheets or hopefully into some type of a single program, etc., etc. This part is hugely important, okay? Rather overlooked, in my view. There needs to be investment here to make sure they're trained to do it properly, because rubbish in and rubbish out. It's that simple. So the input is extremely important, which leads you then to data. And as I said at the table yesterday, my research background, there has never been a decision made on data. No one has ever changed the world by looking at data. Data is numbers, it's necessary, it's useless. Numbers are useless, okay? It's information that's important. So you have to have something that brings you to a point of information. It is telling me something. All these numbers squiggled on the sheet are giving me something to know. This here is the important bit. I need intelligence on the board. I need to be able to make a decision. And I can't make a decision based on just information. I need intelligence from my systems. And that's the other thing that Strata has done for us hugely. Here's our dashboard. And this tells me a huge amount of information about my referral. Can you imagine how important referral activity is to a service? That's where they come in, you know? If you analyse referral, everything else falls out of that, surely. Because if you know how many patients came in and why they came in, or why they didn't come in, is another important one. So this dashboard has been assembled on my referral point, and I think that's really important. Acute admission is up 12%. Why do I know that? In 1 year, is the increase of the people who are being referred into my acute rapid response and beds. And if they weren't there, it's reasonable to assume they would go to the acute. And I think that's fairly striking. Now, this is an ROI question, a return on investment question. Have we saved money by this? Is this a better way of doing things, or is it just something that looks nice on the outside but is not benefiting the organisation? This proves it. This here is the ethnic mix of my referrals. In London, as you can imagine, each borough is very different ethnically. So in your inner London areas, very high ethnic mix. And by the time you get to northeast London, if you're in one of the inner boroughs, Tower Hamlets, you will have a 40% ethnic mix. In Havering, you've got a 5%. Okay? So and that's only 5 miles, 8 miles away from each other. So huge variations. So this talks to me about these are your the ethnic mix. And I'm not going to go through all these graphs because I think it's too arduous. What I'm trying to demonstrate to you is the type of questions we can ask as a board about our referral activity. So who uses them? And is that changing? Are we seeing an awful lot more Asian population using services for diabetes, for example? Or, more importantly, are we seeing a fall off on Asian populations using diabetic services? Because then we'd be worried because the prevalence of diabetes in that ethnic group is higher. So if they're falling off, now I'm worried because I've got an unmet need on the community, and how are we going to engage them? How are we going to go out and reach those hard to reach groups? This is diabetes, and you can see here this is percentage utilisation of services by age group, okay? And so we can look at this and say, right, here's diabetes, there's an issue here. This is who's at risk. This is Clint's phrase, not mine, but I really like it, which are who are the healthy sick. Who are the people who are using our community services, but for example, not registered with the community matron, not registered with a specialist in diabetes, but they're using our services and we know they've got diabetes, so why aren't they using the right services? So it allows us to target services at those people who will benefit most from the community services specialised in their areas. So I hope what people are seeing is a hope of taking you on a journey to say, this was our problem. This is where we wanted to get to, this was our vision. This was the solution generation, this is what we've done, this is how it works, these are the benefits. Have people come on that journey with me? Are you with me? Yes? Any questions at this point? Okay. Yes, Kathy.
So the in-hospital work with the process change and making it a process, what does that look like?
So what we have is a collaborative team within the acute hospital where I provide case managers into a discharge team. Our case managers from our borough, because you can imagine the acute hospital that we work with in the main sees patients from Essex, from Havering, from Redbridge, from all the different boroughs, okay? And each borough puts people in to work in the discharge team. So the team associated with the people who live in my borough, who are accessible to my community services, because that's the other rule. The commissioner will only pay me for people I see who are registered with the GP within their area. If I see a patient registered outside, I get no beans. So I don't do it. Because there's another borough that will see them, so we divert the patient to the right service. But that's difficult, because some of the services we offer are not offered somewhere else, okay? So my team work in there. Clint has configured the bed matching component of Strata for the movement of clients from the acute hospital into our community beds. So they're identified by our case manager in collaboration with the acute discharge team, and then they're fed through the system and discharged to our hospital.